Dr. Edward Wolin. I'm a medical oncologist, a neuroendocrine oncologist, directing the Carcinoid and Neuroendocrine Tumor Center at Mount Sinai Hospital, and I'll be discussing the neuroendocrine tumor highlights from the ENDO meeting 2020. Just as a way of introduction, to remind you, what are neuroendocrine tumors? These are tumors that start from endocrine cells, the kind that produce peptide hormones, scattered throughout the body. And there are multiple kinds, and multiple hormones can be made by these tumors. So, of course, they're of particular interest to endocrinologists. It's a tumor which is increasing rapidly in incidence. There's been approximately a 500% increase in incidence in the last 30 years. And it's becoming more and more common, although still considered a rare disease. And certainly many of the things we'll be talking about today are rare. Managing these tumors is a complex endeavor. And what we have at Mount Sinai is a multidisciplinary team, including such specialties as oncology, radiology, pathology, family practice, gastroenterology, endocrinology, pulmonary disease, cardiology, and multiple other specialties all getting together every week to discuss management. And this is a model which I think is very valuable. The ENDO annual meeting took place in a virtual fashion on March 28th to 31st in San Francisco. The actual live event was canceled because of COVID-19, but the abstracts were published in the Journal of Endocrine Society. The first thing I'll be talking about is Cushing's syndrome from neuroendocrine tumors. These tumors produce a variety of hormones, as we mentioned, including such things as ACTH or CRH, which can lead to Cushing's syndrome. There was an abstract on Cushing's syndrome, periodic Cushing's, in a patient presenting with intestinal neuroendocrine tumor. It was described as the first case of Cushing's syndrome. I'm not sure it's actually the first case. I have seen cases as well in the past mediated by CRH. But I think that it is certainly one of the first reported, and just be aware that they don't have to start in the thorax, even though that's the most common site. Lung or thymus would be more common than intestine. Another paper by John et al., ectopic Cushing's due to metastatic neuroendocrine tumor of the breast, 38-year-old with ACTH-dependent Cushing's syndrome, presenting as a breast primary that ultimately metastasized and responded to the usual types of therapy for this disease. Now, as we talk about usual types of therapy, ectopic Cushing's can be treated with such agents as metyrapone, if it's available. Could also be treated with bilateral adrenalectomy, which certainly is a definitive cure for this disease. But an exciting new therapy presented by Elena Thampi and colleagues, called an underutilized but safe and efficacious drug to treat acute severe Cushing's syndrome, case report of ectopic ACTH syndrome from neuroendocrine malignancies. In this paper, a low-dose, non-sedating etomidate rapidly lowered cortisol, and they presented two cases, both of which had rapid improvement in Cushing's syndrome with this drug. It's not necessarily a permanent treatment, but it certainly can stabilize people, get the disease under control, and in some cases allow them to be stabilized until either the primary tumor can be removed or the adrenal glands can be resected. Another interesting paper was psychiatric symptoms associated with multiple hormone secretions by the same tumor. We know that neuroendocrine tumors that are functional don't only make one hormone. You might call a hormone that production of gastrin a gastrinoma, one that makes insulin an insulinoma, but we also have tumors that make gastrin and insulin at the same time. There was a case that was discussed causing psychiatric symptoms from co-secretion of multiple hormones by a neuroendocrine tumor. This tumor was making insulin and serotonin and IGF-1, led to psychosis And after the tumor was treated, the psychiatric symptoms improved. It's not clear exactly what the mix of the hormones was that was doing it, but clearly you can have more than one hormone, and it's a good idea in newly diagnosed patients to measure a panel of hormones. Okay. Another paper presented by Maya Lee et al., venous thromboembolic events and MEN1, entitled "Are venous thromboembolic events increased in patients with multiple endocrine neoplasia type 1, MEN1? The answer was yes. There was a twofold higher incidence of venous thrombosis than in the general population. However, 84% of these patients had pancreatic neuroendocrine tumors, which is a known cause of thromboembolic events. So I'm not sure whether it's the MEN1 per se or the fact that the high percentage of the patients have pancreatic neuroendocrine tumors. But just be aware that these patients with MEN1 syndrome may be hypercoagulable. Acromegaly caused by growth hormone release from neuroendocrine tumors has also been reported. It's a rare condition. There was a discussion of a case of acromegaly from a bronchial neuroendocrine tumor in a 42-year-old with small cell lung cancer treated with chemotherapy and radiation therapy, and developed the signs and symptoms of acromegaly and was found to have an elevated growth hormone level of 73 picograms per milliliter. And the biopsy demonstrated an ACTH-producing pulmonary neuroendocrine tumor that was actually not a small cell lung cancer, but a more well-differentiated type of pulmonary neuroendocrine tumor, presumably a typical or atypical carcinoid. And the patient was successfully treated with somatostatin analog and a left pneumonectomy. Another interesting presentation is a glucagonoma presenting with a skin rash. A paper was presented at this meeting with undiagnosed chronic eczema. And it turned out that after a long and difficult course trying to understand the nature of this eczema and why it was not responding to steroids, a diagnosis of necretory microlytic erythema from glucagonoma syndrome was made, and patient was found to have a markedly elevated glucagon level at 923 picograms per milliliter and was successfully treated surgically. So, along with elevated blood sugar and the other stigmata of glucagonoma syndrome, you can certainly have a skin rash. And it's a very characteristic skin rash for people who have seen it before, but unfortunately most people have not, and it often is confused with eczema and other skin conditions. A paper was reported on somatostatin analog therapy, an assessment of nurses' preferences for injecting lanreotide, autogel, or versus the alternative, which would be octreotide long-acting release. And the 97.8% of the nurses said they prefer injecting lanreotide. Not surprising, since the needle is a very short one compared to the needle that's necessary for the intramuscular injection of octreotide LAR. The lanreotide injection is with a large bore subcutaneous needle. It's not as deep an injection. The next issue I wanted to discuss was pheochromocytomas and paragangliomas. These are tumors that can produce catecholamines. The pheochromocytomas made in the adrenal glands, the paragangliomas in extraadrenal sites. And it's been traditionally an extremely difficult disease to treat. One of the really exciting things that's come out recently is the use of HSA I-131 MIBG as a therapy. This is a norepinephrine analog, which binds to the norepinephrine receptors on these tumor cells and is able to cause significant destruction from the I-131, which is attached to the molecule. The high potency variant, which is called HSA, I-131 MIBG, the HSA goes by the brand name of Azedra, but this is the molecule, was FDA approved in 2018 based on study IB12B. There's data that was published at this meeting on up-to-date new information on the study, and it's continuing to show tremendous promise with an overall survival rate of 73% at 2 years, 47% at 4 years, 41% at 5 years, particularly when at least 2 therapeutic doses were given. These were doses of 500 millicuries each, with high dose. In addition to the exciting results with HSA I-131 MIBG, a abstract was presented on temozolomide as a chemotherapy in metastatic pheochromocytomas and paragangliomas. Temozolomide is an alkylating agent which is active in a variety of types of neuroendocrine tumors, but hasn't really been explored in pheochromocytomas and paragangliomas before. There were 2 cases reported, one in a 14-year-old girl and one in a 31-year-old lady, who both had metastatic disease, and in both cases had an objective response to temozolomide, one of them with a decrease in tumor size, which would be called a partial response, and the other one with a complete response. So I think this definitely deserves more study and potentially would be a practice-changing type of chemotherapy for this disease. In summary, neuroendocrine tumors are a rare and diverse group of tumors. They produce multiple hormones, which can be a source of confusion, both with respect to diagnosis and treatment. The new data that came out at the ENDO 2000 meeting highlight the problems in diagnosing rare hormonal syndromes, novel therapies of rare hormonal syndromes, and emphasizing that despite the rarity of these diseases, that rigorous clinical trials are needed to optimize therapy in the future. So it was a great pleasure reviewing this information with you, and thank you.